cells that are digesting this cell. So without the context, you would say this is alcoholic hepatitis, but in the context, we'll say it's non-alcoholic fatty liver disease. And that's where the name came from. So and here's another case, but a patient a lot older with a longer history of obesity. And the biopsy shows, again, the same features we saw in the other patient, but now we see the development of cirrhosis. Here we have expansion from one portal tract to the other, which is the functional unit of the liver. You have this bridging fibrosis forming a nodule, and that's development of cirrhosis. So initially, during my fellowship, we all thought that fatty liver disease was benign. It only had fat, there was no inflammation, lose some weight, and things will go better. Well, we still knew we have to lose weight, but now we understand that fatty liver disease, just like alcohol, just like hepatitis C, just like any chronic liver disease, is a progressive disease, has a full spectrum representation, and leads to cirrhosis. And it's becoming rapidly one of the main indications for liver transplant, in particular in the United States. But is fatty liver disease only due to obesity? No, there's all kinds of different causes of fatty liver disease. So we see it in other types of liver disease. Wilson's disease, autoimmune, biohepatitis, especially genotype 3, then of course alcohol, we just talked about that. We see it in drugs, for example, prednisone for fatty liver disease, arterial bypass, which we don't do much anymore. What is fatty liver disease due to decrease in apolipoprotein? Malnutrition, like quadricore, for the same reason. Protein malnutrition, the liver can no longer export the fat out of the liver, so it retains this fat that leads to fatty liver. Genetic deficiencies in liver proteins. Then you have diabetes, hyperlipidemia, obesity, and idiopathic. So we've recognized now that this entity really is syndrome X, it's this metabolic syndrome, it's diabetic or pre-diabetic, and this is what is the main cause of fatty liver in the United States. And the other causes are secondary causes of fatty liver disease. So how do we diagnose fatty liver disease? Recognize the risk factors. Ultrasound is really the easiest, fastest, and non-invasive way to show fatty liver on these patients. Unfortunately, some patients who are very obese, they're not very epigenic, so we have to resort to CT or MRI. Now we have very sophisticated MRI that can actually quantify the fat in the liver. We exclude other liver diseases, like hepatitis C, hepatitis B, wisdom about their alcohol. We're very attentive to autoimmune hepatitis in female patients in particular. A lot of these patients are on statins, Lipitor, Zocor, Cristal, etc. There's a lot of confusion because those medications can lead to transaminitis or liver enzymes. However, in that scenario, it's not due to toxicity to liver cells, it's due to change in metabolism of these enzymes. So it does make things confusing when we want to treat patients because we don't know if the enzymes are due to liver toxicity or fatty liver or the statins. But patients who have high cholesterol should not be discontinuing our statins just because the enzymes are elevated. So this is due to the main cause, as I alluded to, of non-alcoholic fatty liver disease is obesity. You're familiar with the definition of obesity, which is body mass index. I'm not going to go over the slides in great detail, but in America, roughly 1/3 of the adult population is overweight or obese, or has a BMI greater than 30. And CDC this is a bit outdated, but CDC regularly publishes the American Fat Map, which describes the percentage of individuals in each state that have a BMI greater than 30. And this thing is a lot better now. So there are some states where 1/3 to 45, 50% of patients or individuals have a BMI greater than 30. And we are the fattest nation in the world. So, unfortunately. So what is this relationship between fatty liver, insulins, and obesity? I'll just go over the data So that's where the waist-to-hip ratio comes in as a predictor of fatty liver. We have good indirect data that shows that the presumed diagnosis of fatty liver disease, the odds ratio of that presumed diagnosis is linearly related, whether it's men or women, to increases in BMI. We know that the prevalence of type 2 diabetes goes up with elevated BMI, and we know that the levels of cholesterol, total cholesterol goes up with elevated BMI, and also the levels of high-density lipoproteins go down and low density goes up, both in men and in women with increased BMI. So how does that relate to fatty liver? Well, we have very old data that has been confirmed umpteen times that as blood sugar goes up and as weight-to-hip ratio goes up, so does your odds ratio for having fatty liver and also for the quantity of fatty liver. We know that patients with NAFL have higher blood sugars, they have higher insulin, and by definition have a higher rate of insulin resistance, right? Which is defined by high levels of insulin required to attain the same level of glycemic control. Why? Because the receptors in the liver are not working anymore. And in fact, if you look at cohorts of patients with biopsy-proven fatty liver, even those that have a relatively normal BMI still have a higher level of insulin resistance. And that tells us that it's not only obesity that is a risk factor, but there is a genetic predisposition. And some of these patients are destined in the right environment with poor diet and high BMI to develop fatty liver. So what's happening? This is the quote-unquote normal homeostasis of fatty liver with trafficking between the adipocytes and the abdomen, which is metabolically active, to the hepatocytes with passage of the triglycerides into the mitochondria for beta oxidation. So not only is the movement of fatty livers between the adipocytes and the liver, but also free fatty acids coming in from the diet. So how does fatty liver happen? You have not only an increase in free fatty acids from the diet, but you have disrupted signaling, insulin signaling at the level of the liver, of the fat cells and of the liver, which leads to the retention of triglycerides, decreased beta oxidation, and the retention of triglycerides within the cytoplasm of the hepatocytes. And it's this highly reactive lipids that lead to toxicity to the liver by mechanisms that are changing, that are proposed every month. There are a lot of different mechanisms that are thought to be playing in this. Some patients will just have simple fatty liver. Some patients have fatty liver with inflammation. We really don't know what creates that difference. There's a lot of genetic factors that are being looked into, but it is a multiple hit process. So the prevalence of fatty liver is quite hard to estimate because people diagnose it in different ways. The ultimate diagnosis of liver disease is made by a liver biopsy. We can't biopsy everybody. Biopsy has risks. And really in medicine, non-research medicine, we have a tendency to biopsy a patient if we think that the result will lead to a change in outcome or in treatment. If I have enough evidence in a patient to suspect fatty liver, they're obese, hepatitis B and C is negative, they're not drinking, ultrasound shows fatty liver, LT is greater than AST, then rather than do a biopsy, I'll say, lose some weight, increase your carbohydrate intake, I'll see you in a few months, in 6 months, and I'll redo an ultrasound, and if they lost weight, enzymes will come down, and the fatty liver will regress. So the data on the prevalence correlate, if you just look at the, if you just project the estimation of how many patients with obesity have fatty liver and look at the obesity rates, we come to extraordinary numbers of patients with fatty liver disease, which are probably underestimated. And this has a direct impact not only in the patients we see, but in our ability to transplant patients. Because these fatty livers are not good for transplant. They're not, these donors of fatty liver are not good. And I can tell you that when our surgeons go out for procurement for a liver from a deceased donor, I would say at least 1 out of 4 times, or 1 out of 3 times, we have to reject those livers because of fatty liver disease. They tend to reject livers that have more than 30% of fat in the liver. And that the reason that those livers don't work is because they already have a lot of, they have the cytokine aura in that liver, which is not good for the transplant. And then because of the accumulation of fat within the liver cells, which distorts the liver cells and puts pressures on the sinusoids, these livers do not perfuse well with transplant, and the patients lose their liver. So not only is the obesity rates in America leading to liver disease, it's also affecting our ability to treat other patients. And it is now recognized as the #1 cause of liver disease in the United States, far outweighing alcohol and hepatitis C and hepatitis B. Of course, that doesn't mean that those other conditions are not important. It all depends on which population you look at, right? In Asian population, I would say that fatty liver disease is not the #1. We have to think of hepatitis B as an example. Interestingly,